So let's just go back to our case. We've talked a little bit about the presentation. The patient's been brought in on a Section 17. It's clearly difficult to assess and manage. As a result of that, there's been a decision to put the person on a Form 1 to facilitate further assessment. In this case, the patient has been brought by police to a local hospital, which is not a Schedule 1 facility. The Mental Health Act, as you all know, states that once somebody's on a Form 1, the assessment needs to be done at a Schedule 1 facility where a psychiatric assessment can be facilitated. So in this case, the emergency room physician calls the Schedule 1 facility, and the response is that the emergency room at the Schedule 1 facility is in fact over capacity and they are unable to accept the patient at the present time. The Schedule 1 facility then says they'll give you a call back in a couple of hours and give you an update as to their situation, but for now the patient has to stay in your non-Schedule 1 emergency room. So the question then is, what should be done next? The Mental Health Act in Ontario actually speaks specifically to the issue of transfer of a patient to a Schedule 1 facility. And I'm just going to read what the Mental Health Act says about this, and then we can talk a little bit about some of these issues. So a Form 1, or application for psychiatric assessment, is sufficient authority for 7 days from and including the day on which it was signed by the physician to A, for any person to take the patient who is the subject of the Form 1 in custody to a psychiatric facility forthwith, and B, to detain that person who is the subject of a Form 1 at the psychiatric facility and to restrain, observe, and examine him or her in that facility for not more than 72 hours. So a couple of things in the Mental Health Act, just to be clear. The first is that unlike Section 17 and the Form 2 under Section 16, which specifically prescribes that the police are involved in taking custody of the person and bringing them to the psychiatric facility, the Mental Health Act actually speaks to the issue of a Form 1 as being any person can take the patient forthwith to a psychiatric facility. In practice, in our area, in many parts of Ontario, police are involved in taking that person in custody and transfer. But as we know, that takes up a lot of police time, and I'm just flagging in the Mental Health Act, it doesn't specifically say that that has to be police that do that task. The second thing that's important in this piece of the legislation is the whole concept of taking somebody forthwith. And I know that there are concerns about the amount of time it might take for somebody who is in a non-Schedule 1 emergency room to be transferred to a Schedule 1 setting for the psychiatric examination. So one of the difficult parts of interpreting this piece of the Mental Health Act is that there really is no definition under this section that describes what does forthwith mean. Does it mean in the next 30 minutes? Does it mean within a day? Does it mean within a week? I know in terms of clinical practice, if you're in a Schedule 1 facility and there's police often holding the person there, a pending transfer, forthwith would be nice to interpret as something that happens pretty quickly. But from the Schedule 1 facility perspective, often it's difficult to accommodate as quickly as these non-Schedule 1 facility might like. There's been also, in terms of reviewing definitions for forthwith in other areas of case law, there really has not been anything clear that's come from the court system or from administrative tribunals to help clarify how long forthwith actually is. And in fact, there really is only a case-by-case approach that's been taken regarding the term forthwith in terms of mental health legislation broadly. So here's just a couple of the examples from case law that just help perhaps put some perspective of how best to interpret forthwith, because it can be a little bit of a frustration, I think, on the side of both the non-Schedule 1 and the Schedule 1 facility. One case looked at the whole issue of forthwith as it applies to authority of the police, or Section 17, and a Form 2, or Section 16 of the Mental Health Act. And in this particular case, which was in 2005, which is outlined in the second paragraph here, basically a court which looked at some of the facts of the case and found out that forthwith in this particular situation had meant 5 hours, stated that they felt that the 5-hour delay was not unreasonable. The court also stated that it was difficult to determine what is forthwith specifically in terms of a definition, and that any conclusion about forthwith probably would depend on the individual circumstances at the time. So that's one piece of case law that was related to the Mental Health Act, but not specific to a Form 1. A couple of other examples. One was in 1995, and this was Starneman versus Penetang. And in this case, the individual subject on the Form 1 was transferred to a hospital for his assessment 2 days after the psychiatrist applied for the assessment. The court didn't make a final determination about how they felt about the definition of forthwith being equal to 2 days, but what was noted was that the 2-day delay in the transfer was not objected to by either parties in the case. So that didn't come up as a concern in this particular case. So we've got a comment on a 5-hour delay, and now this is a 2-day delay. A last example of case law looked more specifically at the use of the word forthwith within the criminal code. And in Ontario versus Faneuf, the court concluded that the provisions of the criminal code relating to the transfer of a detainee to a hospital for assessment could not be interpreted as requiring the transfer to be immediate. So this is a finding that forthwith does not equal immediate, and it was stated in this decision that practically speaking, there will inevitably be some time required to move the accused, in this case, from a detention center to the hospital, and there was some acceptance that forthwith was really defined more as when it is practically possible without any unnecessary delays. So really, when we're thinking about how to apply the word forthwith within mental health legislation, particularly the issue between a non-Schedule I facility and a Schedule I facility, there are no specific rules, but there does seem to be some case law that suggests it may not, unfortunately, be immediate. It should be immediate if both sides can facilitate that, but if there are practical delays within the system, then forthwith may include a longer period of time than one might expect. Okay, so back to our case study. So our young lady is now sitting on a Form 1 in the non-Schedule I facility. The Schedule I facility has not been able to transfer her forthwith. And you go back in to reassess her, and what you see is that she remains very agitated. And when you approach her for further assessment, she throws a jug of water at you. You offer her medication to settle, and she refuses. So the next question then is, you've got a young woman on a Form 1 who's clearly agitated, unmanageable, and the question now is, can you medicate her? So this part of the case study then moves us into the issue of the Healthcare Consent Act. So the Healthcare Consent Act, which is another act within Ontario, speaks specifically for establishing a single set of rules around the whole concept of consent to treatment. What we have to remember under the Healthcare Consent Act is that the rules are the same for all patients and all treatments in all settings. The Healthcare Consent Act governs health practitioners, including physicians, so it's not just with respect to physicians, it's anyone who is a licensed health practitioner. And it states that for treatment to be administered, informed consent is required, and the only exception is emergency treatment. So the first consideration when we think about this case, if this young woman's throwing water at the attending physician, is emergency treatment appropriate at this time? So what is the definition of emergency treatment? The Healthcare Consent Act basically says that if the person for whom the treatment is proposed is apparently experiencing severe suffering or is at risk, if treatment is not administered, of sustaining serious bodily harm, then emergency treatment is warranted. And the health practitioner must decide whether there is an emergency in place. So one of the things to consider with respect to this case is if you're offering medication, is that emergency treatment to try and help contain how she's doing? And is this something that's warranted in this particular case example? As the Healthcare Consent Act suggests, that before giving somebody treatment, if it's not an emergency, then informed consent has to be obtained. In order to get informed consent, the patient must receive information about the nature of the treatment, expected benefits, material risks and side effects, any alternative courses of action, and the likely consequences of not having the treatment. So for any healthcare practitioner, in order to demonstrate that they've got informed consent, a minimum of information covering these areas is required in order to be able to proceed with treatment. In Ontario, we're allowed to presume that somebody is capable of making their own treatment decisions. There's no age of capacity in Ontario, and we really only start challenging the issue of somebody's capacity when we have grounds to believe that the person is incapable with respect to the treatment. So in this case example, this situation, there's a possibility that a young lady could have been given medication in terms of restraining her because she's acting out. If there was concerns that she was going to harm herself, or there would be some grounds for considering giving her emergency treatment in her situation. If, however, after throwing the jug of water, she was able to sit quietly and have a conversation, then it would probably be a good idea to review whether or not she's accepting of medication, to quickly outline what the medication is for. And then, as a clinician, you could presume capacity unless there was some new evidence that she presented with that made you want to explore whether or not she was in fact incapable with respect to giving a treatment decision around medication that was being proposed. If there was a concern in terms of her presentation that made you feel that an evaluation of capacity was appropriate at that point in time, then these are some of the things that you'd have to turn your mind to. Keep in mind that the capacity depends on treatment, and a person may be incapable with respect to one treatment and capable with respect to another. There is no such thing as a global incapacity in a person. And the other thing is that capacity depends on time. A person may be incapable at one time and then capable at another, and capacity therefore is something that needs to be reevaluated over periods of time.